You hear a clinician called Jonathan Cross giving a presentation to a group of healthcare providers. You now have 90 seconds to read the questions. My name's Jonathan Cross, and I'm here today to discuss the somewhat controversial topic of unrestricted visiting hours throughout all departments of a hospital, including ICUs, our intensive care units. Across the globe, in every ICU, regardless of discipline or location, determining appropriate visiting hours is and will likely remain a challenge. Traditionally, physicians, nurses, and other clinical disciplines have behaved as though critical care units are designed for them rather than for patients and their loved ones. It now appears the tide is turning on the part of clinicians to provide enhanced benefits to patients and their families by making more time available for visits. This is seen by many as a positive change, but with any new initiative, there are those who oppose the shift in culture and cling steadfast to more conventional ways. So what are the problems associated with open visiting hours? Without question, liberal or unrestricted visiting hours can be more burdensome for clinicians who work in the ICU, particularly nurses, because of the potential disruption of daily workflow that might result from consistent family presence at the bedside. As most healthcare providers assert, to navigate the bedside of critically ill patients without family presence is less cumbersome. It's this that's prompting the naysayers to pose questions like, how will open hours affect the staff? Will it lead to adverse effects on patients or staff? The real question, however, is why open visiting hours causes such concern among critical care personnel. Multiple studies have been done and have repeatedly reported no adverse effects, such as infections or unstable vital signs, or on quality of care, and yet clinicians continue to cite concerns about safety as justification for restricted visiting hours. There was a recent study published in Intensive Care Medicine by Gianni and colleagues who identified the level of burnout among physicians and nurses in 8 Italian ICUs prior to and at 6 and 12 months after liberalising visiting hours. This study demonstrated 2 important findings. Firstly, there was a 10% increase in the reported level of burnout at both time periods after visiting hours were opened. This increase was seen predominantly among the nurses. Secondly, despite the increase in the reported levels of burnout, the opinion of the physicians and nurses toward having unrestricted visiting hours remained favourable and essentially unchanged before and after the policy change. This latter finding is an important one and represents a significant shift in attitude. Both physicians and nurses acknowledge the importance of open visiting hours to patients and their families. This suggests that even at the risk of their own discomfort, providing enhanced benefits by way of additional family time for patients is a priority for clinicians. An important issue that was not covered in the trial is the potential of family burnout. A prolonged presence at the bedside may expose family members to another type of anxiety caused by frequent interruption due to healthcare professionals who may not always prioritize communication with families, especially when unexpected deterioration of the patient occurs and rapid life-saving measures have to be taken. Therefore, opening of visiting policies should be accompanied by the implementation of a consistent family support policy, including social work, palliative care, and other counselling services to improve communication with families. While some supposed benefits of open visiting hours are clearly beneficial, such as allowing for families with difficult work schedules to still visit or enhancing shared decision-making about patient care, there are also those that seem to stretch the realm of possibility. One such controversial benefit is facilitating family presence for CPR and procedures, areas traditionally off limits to family and friends. At such a time as CPR, for instance, it's suggested that witnessing this will in some way improve family outcomes and provide closure. Surely the level of stress during such a time on the parts of both staff and witnesses would be too much, and it's during such times that families should be requested to leave. I'd like to state here that open visiting hours does not mean visiting without rules. Family member behaviour can be restricted if it is disruptive to the care of the patient or other patients in the ICU, and family members can be expected to follow the same rules concerning infection control as ICU clinicians. These are the facts. Administration as well as families must be educated to understand the demand that open visiting hours presents. Clinicians must also continue to be supported. By doing so, we may just usher in a new era in which patient-centred, family-centred, and clinician-centred care can all be one and the same. As clinicians who are loyal to the interests of our patients, we owe it to them to provide them the kind of environment in which critical care and death have occurred for many years outside the hospital, surrounded by the people they care about the most, rather than by strangers. You hear an interview with a midwife called Susan Porter, who's talking about when to cut the umbilical cord. You now have 90 seconds to read the questions. Today we're talking with midwife Susan Porter about a rather controversial topic. Susan, why is the question of when to cut the umbilical cord of a newborn still so significant? And can you give us a brief history of the subject?
Well, you're right in that this question has always been a remarkably controversial topic, and some new research carried out over 8 maternity units across the UK indicates there's good reason for never having let it go, as the evidence now seems to suggest that delaying clamping and cutting the cord after birth could improve survival, specifically in babies that are born prematurely. It all started in the 1960s. Shockingly, before that time, women were still regularly having massive bleeding at the time of childbirth and were dying, which then prompted the testing of a new drug, an injection that clamped the womb down within seconds. It was the magic bullet they'd been looking for because it appeared to be very effective at preventing postpartum hemorrhaging. But of course, there were concerns about that too.
Can you tell us more about that?
One of the worries was that it worked so well that it would squeeze extra blood into the baby, effectively filling the baby with blood. So they very quickly developed the practice of clamping the umbilical cord only moments after delivery. Obviously, clamping is inevitably necessary, but thinking has changed so much now that it's a little strange to think that even in the 1980s, the only reason for not clamping within a 10-second time frame was if you dropped the clamp and had to go and get another one. In other words, it was immediate.
And what happens if we don't clamp a baby's cord?
Well, the circulation between the placenta and the baby will continue for a period, and recent research has shown that it probably continues for longer than we'd previously thought. So if you keep the baby at more or less the same level as the mother, and just don't touch the cord, that flow will continue. That's how the baby breathes before it's born, so you need a bit of a transition for the baby to start breathing through its own lungs. Particularly if the baby's had a vaginal birth, as it's been squeezed in all sorts of ways. And maybe just leaving the baby alone for a few minutes allows it to stabilize its own heart system and also establish its own respiration. It sounds very unscientific, but it's a system that's been designed to work that way, and it's us interfering early that was changing that system.
What's the standard waiting time before clamping these days?
People typically use either 30 or 60 seconds, which is still fairly quick. I find it amazing that in the age of potentially sending a person to Mars, the best time to clamp still eludes us. In one unit I know of, for preterm babies, they absolutely delay. Healthcare professionals to this day still argue about it. The problem is that there have been dozens of previous trials, and they were very poorly executed. The trials all showed it was better to wait, but scientifically, nobody really believed the results. They simply didn't trust them. The UK trials seem to have demonstrated very clearly that for preterm babies at least, waiting is optimal. The unit I just mentioned now waits 2 minutes.
And what's your take on the benefits?
If it reduces the chance of a preterm baby dying, that's the best possible outcome. I think parents understand the logic. I doubt a parent would say they don't want it. They'd say, yes, I can see the benefits of trying this. And especially if it's explained to them that the potential harms of letting the baby go cold are far outweighed by the increased chance of survival. An interesting offshoot of this is the positive change for the mother, as it reduces what was once the norm of mothers having their babies transferred away from them, where the first thing they see is a photograph.
Based on what you see, how likely is it that extended times will become universal?
In babies that are born early, all the organs are still immature, and that means both its heart and the blood vessels in the brain are not fully developed yet. So one of the big problems is hemorrhagic stroke. Also, they're not ready to start breathing on their own, so just by leaving the cord alone, there is better oxygenated blood in the placenta than there is in the baby. The cord gives them access to this. It's essentially a backup to allow more time for the baby to establish its own respiration. This really can't be denied or disputed any longer. I mean, what are the drawbacks? I think change will be gradual across the board, and in years to come, we'll look back on these days and ask ourselves what took us so long.